Well, hello, everyone. Thank you, and welcome to the next of our series of non-operative care webinars, our efforts to try to make care better for children with scoliosis. Uh, uh, better understanding the whole range of possibilities that are available for conservative treatment. I've been really thrilled by the surgeons, physical therapists, orthotists, and again, I have my partner, Dr. Benjamin Roye, on the phone, and through his Zoom, you're going to hear a little bit about exciting, cutting-edge work that Ben's really forging forward on around best practices in conservative care. I want to thank Prachi and Amber over here for all the help in management and vision of this series. And I'll just ask Amber and Prachi quickly to add a couple sort of bookkeeping.
Hi, everyone. I hope you can hear me. I just want to go through, as he said, some housekeeping issues. First of all, welcome everyone. And we just want to advertise our next Lunch and Learn is March 4th. So make sure to sign up for that one. And we are also now finalized our 10th annual non-operative scoliosis meeting that will be in person, but also via Zoom for those who cannot attend in person. But it's a great full day event on September 26th in the fall. And again, it's our 10th annual one. So look for some exciting news about the agenda and speakers and all of that to come. And lastly, we just want to support our colleagues in our Cerebral Palsy Center. They are also starting a Lunch and Learn series, and their first one will be March 7th. So I know it's a little close to our Lunch and Learn. We'll try to get those more separate in the future. But again, ours is March 4th, and the Cerebral Palsy Center's Lunch and Learn is March 7th. So thank you again for everyone's here, and let's get started.
All right, so I think I'll get things started here. Let me share my screen. And we'll go to presentation view. Okay, great. Amber, is that showing okay?
Perfect.
Okay, great.
Yes,
okay.
all good.
So thanks, everyone. My name's Benjamin Roye. I work with Amber and Prachi and Dr. Vitale and everyone at Columbia. I've been there for a long time. And I'm going to talk to you a little bit about bracing today in idiopathic scoliosis with a focus on juveniles. And sort of maybe want to alter the way that we think about bracing, what our goals are, and give a little bit of a comparison to VBT a little bit there. That's kind of what we're talking about when we talk about external and internal bracing. Okay, so we do have some disclosures. We get some support for our research and our fellowships, but nothing directly related to this talk. So what are we going to talk about today? Well, we're going to start by looking at some general principles and indicating brace treatment for idiopathic scoliosis. We're going to review some of the existing indications in the literature for different age groups. Going to have a brief foray into vertebral body tethering, or VBT, and then going to kind of review the literature on part-time and full-time brace prescriptions, and then a summary and general recommendations. So what are our goals of treatment? I have a big stop sign here because that's sort of been the traditional way we think about things, which is to halt the prevention of scoliosis. We're preventing progression. We're not generally thinking about making it better. Infantile scoliosis, which is the very young kids under age 3, sometimes we are looking to cure those kids with bracing or conservative treatment. But that's not generally what we think of for most of the older age groups. However, and this is a little teaser, right? I think we may need to rethink this concept going forward, even in our older kids. So generally speaking, what do we look at when we're initiating brace treatment in kids with scoliosis? There's a lot of different factors that are going to impact our decision-making. Age of onset and skeletal maturity. How old are these kids? And we would also like to push forward, as I think we typically do at these talks, like Sanders score, which is that hand x-ray, is much preferred to the RISR score. You're going to get much less over or underestimation of growth remaining by looking at that hand. What are the curve characteristics? How big is the curve? Where's it located? Is it lumbar? Is it thoracic? Are there two curves? How quickly has it been getting worse is another really important factor. Curves that have been progressing very slowly are probably much less concerned than something that's gotten 15 degrees worse in the last 6 months. What is the family history? If I have a child who's got a mom that had surgery and a sister that had surgery, I'm going to be much more aggressive about putting that child in a brace, even with a very small curve. And then finally, and really important, is what is the patient and family willingness for bracing? It requires active participation. You cannot impose this on them. And there's definitely going to be families where it just ends up not working out. So those are all the factors that we kind of look at when we're trying to make these decisions. So we're going to start with the youngest and work our way up to the oldest. So the infantiles, as I said, these are kids that are under age of 3 at time of presentation. And generally speaking, the standard of care is serial casting for these kids. We put them in casts in the operating room, and a large number of these kids can actually be cured by this. So this is a really impactful treatment. So if casting is so great, why do we even talk about bracing? Well, this is a bracing talk. But really, there are problems with casting in that it generally requires multiple trips to the operating room. And there are real concerns that exist about multiple anesthetic exposures, especially in very young children with developing brains. And the FDA, about almost a decade ago, came up with a black box warning to actually bring this to light. And it's something that people are very aware of and talk about. However, when we look at the literature on bracing in idiopathic scoliosis, it's pretty limited. They're small studies, poorly controlled. However, proof of concept exists. One of the big problems is just getting a brace on such a small child that's going to fit them and that's going to last more than just a couple of months. Actually, right now, Dr. Vitale and myself are part of a randomized clinical trial that are comparing bracing and casting. We're really kind of hoping to come up with a more definitive answer to this in the coming years. So moving on to the juvenile age group. So when we talk about juvenile idiopathic scoliosis in the literature, what that means is these are kids between the ages of 4 and 10 at the time of presentation. And they have a curve greater than 10 degrees, which is the sort of the generally accepted upon curve or definition for scoliosis. Now, compared to the adolescents that develop scoliosis, the juvenile form is less likely to respond to bracing, more likely to progress, and more likely to require surgical intervention. Now, these numbers are pretty wide because the studies are all over the place. When I say like 95% of JIS is going to progress. Now, that may be progressing at all. And certainly, I don't think at this point 50% of all kids with JIS need surgery, but it is much more likely in that population than in the older adolescent age group. There are a few bracing studies in this group, but they really do vary pretty significantly. Success rates vary by almost an order of magnitude, 12% to 95%, and it's really difficult to compare these different studies because they're all over the place in which patients they're using, what kind of curves they're looking at, what type of brace they're using, their brace prescriptions, et cetera. There's all different variables there. Generally speaking, when we do look at the literature, the indications for bracing in JIS, again, these are immature patients. They tend to be RIS or 0, predominantly open triradiate cartilage, because most kids under 10 are going to be there. There will be some exceptions. And typically when the hand x-rays are going to be Sanders 2 or less. Almost every article in the literature is going to look at curves with from a 20 to 45 degree range as far as their indication for initiating bracing. And pretty much every study looks at full-time brace prescriptions with some exceptions. So when we look at the indications for the older age group, just generally speaking, it's hard to talk about bracing in AIS without talking about BRACE. This was the trial. It's over 10 years ago at this point, but it was the first study in this country that really definitively demonstrated brace effectiveness and changed the landscape of bracing, certainly in North America. This was full-time braces in kids that were skeletally immature with Cobb angles between 20 and 40 degrees. And there was a similar Italian study that showed even better outcomes than brace did. So we know that bracing works for scoliosis. Our group actually then kind of working on developing the next steps in this by working on best practice guidelines for bracing in this group, because again, even though we know that it works, there's so many variables. It's really hard to give a cut and dry prescription or indication for it that everyone's going to agree upon. So as you can see, many of the members here in this webinar today were part of this, and we had orthopedists, orthotists, physical therapists, and physiatrists all developing this checklist. And some of the agreed upon measures are relatively broad in scope, but we did come up with some things that I think are really important when considering how we brace these kids going forward. The primary goal of bracing is to prevent or limit curve progression, right? That's what we've talked about. And as I said, that's sort of been the standard out there, and that is the primary goal. We looked at what curves should we brace? Again, you should not brace very small curves under 15 degrees, and there's no role for bracing curves over 60 degrees. That's a huge range, right? There's also no role for bracing skeletally mature patients. And these are going to be your Risser 5 or Sanders 7 with no or really limited growth remaining. We also kind of came up with a definition of higher and lower risk, which was really based on skeletal maturity. We did need to incorporate Risser because across the country, it's still not everyone has discounted the Risser score. So even though everyone does agree Sanders is preferred. And when we're looking at risk, it's important because higher risk patients are going to need a bigger prescription than kids that are lower risk. So what are the different regimens that we see when we're looking at kids with scoliosis? There's a full-time brace regimen, which is generally agreed upon as 16 to 23 hours a day. There's a part-time, which is less than 16, usually about 12 hours, give or take. And then there's the nighttime prescription, which is really only when they're sleeping. So what is the evidence for part-time bracing? In a word, it's really pretty limited. There is increased time in brace. There's certainly evidence for the fact that increased time in the brace equals increased brace success. This is your classic dose response, right? If you take 10 milligrams of Motrin, it won't do anything. 200 milligrams might help your headache. The more you get, the more effective it is. Now, Braced did show this with a dose response curve. And as I mentioned, this Italian study also showed similar results. This is a graph kind of demonstrating the Braced data, which showed that when you were under 6 hours a day, you had about 40% success, which was the same as not wearing a brace at all. So this was less than 6 hours is really not doing anything. And then as you get upwards towards 18 hours a day, the effectiveness rose to about 90%. So a pretty clear dose response. But I can use part-time bracing, right? In a word, absolutely. Even though this may be less than what we're seeing as maximal effectiveness, there's the data from Braced is not perfect. And so we do see part-time bracing being very successful, especially with smaller curves. And there is a pretty robust literature with hypercorrective braces like the Providence and Charleston braces. Now, again, these are not good for every single brace. They're usually isolated to single curves, single lumbar, thoracolumbar curves. And again, there is good evidence for these braces up to 40 degrees. The other time I will often consider part-time bracing, as we'll talk about in a minute, is in the younger patients, classically the juvenile age group. They have more growth remaining, and we might be able to get away with a little bit less of a prescription. So I'm going to take a brief break here from bracing and talk a little bit about VBT. Now, when we look at the holy grail of treatment of scoliosis, we don't just want to prevent progression. We want to correct the deformity and preserve motion, right? So surgery, classic surgery, which is fusion, is great at correcting deformity, but really terrible at preserving motion. So this is what we're looking to accomplish long-term. And that is the concept behind vertebral body tethering, or VBT. That's what it stands for. And basically the way this technique works is we tether the spine on the concave side. This is a surgical procedure. With this tether, we can cinch it down, create some immediate correction, and we're also restricting growth on this convex side of the curve. I have a picture I'll show you in a second that demonstrates this, but growth can still occur on the concave side. So we're getting this sort of differential growth. But you know what? In the end, to me, it sort of sounds like a brace. And that's just another little teaser there. So this is an X-ray. This is a patient with, about a 45, 50 degree right thoracic scoliosis. This is the concave. I'm sorry, that's a mistake. That should be convex. The convex side of the curve is sort of the outside, longer side. The concave is the shallow side. And when we put the tether in, you can see, right, my gosh, we've corrected the spine without fusing it. We're probably limiting motion because there's a rope there, but we are correcting it without fusing it. And we can get growth modulation. So the spine actually grows into a straighter position over time. And this is huge, when we can get this to work. So generally we use VBT in the thoracic spine. That's where right now it's indicated for. It's used in other places too, but the FDA indications, and for most of the studies, is thoracic curves, kids with significant growth remaining, Sanders 3 to 4 generally. You don't want them to be too immature. Kids with open triradiates or Sanders 2 can have overcorrection because they have so much growth left. And other things that tethering's not as good at correcting at, things like shoulder balance and sagittal plane problems like kyphosis. So if those are significantly off, you may need to reconsider this as a technique. There's really good evidence for VBT, certainly proof of concept. The first study was about a decade ago with Samdani down in Philadelphia. He looked at 11 patients. Overall, these patients had significant correction of about 30 degrees of their curves. And rotation even improved a little as well. But if you look at the bottom there, high complication rate, 2 revision surgeries. That may not sound like much, but it's only 11 patients. That's almost 20%. That's much higher than you would expect with standard surgical procedures. So overall, when we're looking at thoracic tethers, the pros and the cons: pros, preserves motion, certainly better than fusion, but may not be quite normal. You still do have an implant spanning the spine. They tend to have shorter hospitalizations and a faster recovery. The cons, it is a higher reoperation rate, and that's, again, about an order of magnitude higher than fusion. Long-term outcomes are unknown. We've been doing this for about a decade. We've got reasonable 5-year follow-up on a population of kids, but as more and more people do it, it's really, we just don't know what's going to happen long-term and how long these results will be held up for. And also, finally, as I mentioned before, we're less able to correct the axial plane, that rib prominence, or the sagittal plane with this technique. So just quickly, in my opinion, the best indication for tethering really is these lumbar curves. Lumbar curves is where most of our spinal motion occurs. And if we can get correction of large curves and growth modulation without fusing, that's huge. And the increased risk of revision surgery is probably worth the risk of a revision surgery. So again, we're getting growth modulation, ideally in vertebral body tethering. This certainly doesn't happen in every case, but that's the goal. But what about embracing? Can we get growth modulation in bracing? I mean, really, when you think about it, what is a tether except for an internal brace, right? They can't take it on and off. Takes a lot to put it in there. You're working around the heart and lungs, certainly. But basically, it's an internal tether. So here we have a 35-degree curve, and there are definitely 35-degree curves that have been tethered. It is part of the indication threshold. And we put them in a brace, and you can see, wow, they look a lot straighter, just like they do when you first put them in a tether. And 2 years later, wow, they've had growth modulation. We now have a 14-degree curve. The kid's a Sanders 5. We avoided surgery, right? And we've avoided any risk of revision surgery. It doesn't always work, but you can absolutely get growth modulation and bracing. And I think that while people have sort of recognized this to be the fact, there's a growing literature looking at this, and I want to talk a little bit more about that right now. And this is sort of our own institutional experience with the juvenile patients looking at bracing, and we see that most smaller curves in kids with juvenile scoliosis do improve with part-time bracing. They are actually getting growth modulation. So we did a single center retrospective cohort study, and these were JIS patients with curves under 25 degrees, so smaller curves. They were all, and then we had 2 groups, the observation group and a part-time bracing group, and these were split up by attending preference. So one attending braced them, one attending observed them. So there was no selection bias from that standpoint. We had a minimum 2-year follow-up, and our outcomes were looking for a curve progression of at least 5 degrees or changing from part-time to full-time bracing. So we had 73 patients, about 60% were observed and 40% were braced. The 2 groups were very similar statistically as far as how large the curve was when they were indicated and how old they were at the time of presentation. And what we saw was that the patients that were put into a brace improved by 5 degrees 3 times more often than observed patients. 70% of patients improved. So this was really a pretty novel finding and something which patients love. And it's a great selling point when we're looking to get compliance. When we looked at who progressed, who got worse, well, we saw the observed patients progress 2.5 times more frequently than the braced patients. So 13% of our observed patients progressed at least 5 degrees in the 2-year time frame, compared to only 13% of the part-time studies. Part-time braced patients. We also looked at some effect modifiers. What were the things that made bracing less effective? Well, these are things that we've known in the past, and we demonstrated them again as well. Larger curve magnitude at time of intervention decreases the likelihood of stabilization, and the older age at intervention also has a higher likelihood of curve progression. So we want to get these kids with smaller curves at a younger age in order to get this growth modulation. That seems to be what we're showing. So the take-home message really from this study was that part-time bracing works. The patients that were only observed and not braced were 2.5 times more likely to progress and over 3 times more likely to get a full-time brace. And that's really what a lot of what we're looking to avoid. Getting compliance with full-time bracing is so difficult. Our patients that were given a part-time brace with these smaller curves were over 3 times more likely to improve compared to the observed cohort. So one of the things that I want to take home from this study and just the concepts that we've learned from VBT as well, which is that We've now got two studies, because there was another similar study to this one that was done in Texas that showed that, anywhere from 20 to 70% of smaller curves can improve with part-time bracing. And the other study I'm referencing was actually done on adolescent patients. These were kids that had a little bit less growth remaining, and I think that's why fewer of them got better, but they were similar curve magnitudes. So we can see improvement with bracing. It's been shown in dozens and dozens of patients in two good studies from major institutions, high-volume institutions. We use growth modulation in many aspects of orthopedic surgery and have used for decades, right? When kids have knock knees or bowed legs, we can use growth modulation by tethering their growth plate to get their limbs to grow into a straighter position. And we're now really trying to take better advantage of that with the spine and potentially even in a non-surgical fashion. My argument is like, why can't we do this with bracing instead of surgery? Now bracing's not going to work for everybody, but I think just to discount bracing as a way to make bigger curves get smaller is short-sighted. So here's just another case study. We have a Sanders 3 girl, premenarchal, 30-degree curve in her lumbar spine. 1 year after bracing, she's just part-time bracing. She's now down to 20 degrees. Now, 2 years after bracing, she's a Sanders 7 and has a 16-degree curve. And if you look at that X-ray from across the room, it's hard to even see that she has anything. So this is a kid who in 2 years of basically wearing the brace in the evening and at night when she slept, no surgery, this is someone who had probably a 75 or 80% risk of progression to surgery without treatment, now has almost no scoliosis. She's almost below that threshold for scoliosis. So this is, again, and I've got many of these types of patients in my practice. And the key really is catching them at the right time. So this is that patient's growth chart. And you can see when we started bracing her, she was a little bit older perhaps, but she was just starting her rapid growth, because you can see her crossing, from the 75th to the 90th percentile for height. So in early Sanders 3, they're growing quickly. These kids, if they wear their brace even a little bit, even 10 hours a day, you can see improvements in their curve. And this is honestly basically the same thing that they're seeing with the tethered patients. They really need to be captured in a phase of growth spurt, not too early so that they overcorrect. But if you catch them too late, they're not going to growth modulate, and probably those tethers are going to break over time and maybe with some loss of correction. So in summary, putting it all together, some of the general principles to consider. Bracing changes the natural history of idiopathic scoliosis. That has been shown unequivocally, in my opinion. Bracing is more effective with smaller curves. This makes sense intuitively. It's been shown to a smaller degree in other studies, but there's been a lot more studies more recently showing it as well. And that's why it doesn't make sense for me to wait till these curves get bigger to initiate bracing. Why should I wait for the curve to get to 25 degrees if I know the brace is more effective when it's 20 degrees? In-brace correction and brace compliance are two critical factors to effectiveness. And these are things that are to some degree within our control. Brace compliance is absolutely within at least the family's control or the patient's control. And in-brace correction is going to depend a lot on your orthotist. So these are things that we need to work on maximizing, because there's other things that we can't control, like how quickly they're growing. Finally, I really want to again emphasize growth modulation is absolutely possible, and I think it's an important selling point and may help motivate patients to be more compliant with their brace. So just kind of briefly going through all my different patients, all different types of patient populations and how to brace them. Who is a good brace candidate for part-time bracing? Even though full-time is the current standard of care, I'm looking to try to change that with this research and actually doing some work with the SRS on doing that as well right now. There really needs to be a reason to change to part-time bracing because of the current gold standard. So when can we think about it? Smaller curves, less than 25 to 30 degrees, part-time might be enough. Curve patterns, single lumbar, thoracolumbar curves with an overcorrecting brace, these might be able to be treated with a part-time brace no matter how large the curve is. And actually, I'm part of another randomized clinical trial looking at this particular question as well. And then finally, skeletal maturity, right? Once peak growth velocity is in the rearview mirror, maybe we don't need to put them in a full-time brace, even with a larger curve, like a 30 or 35-degree curve. If I have a kid who's a Sanders 5 or 6, maybe they don't need to be in a full-time brace, even though the curve's a little bit bigger. Again, no data for this, but I think that that's something which is intuitive to me and that I follow. I'm not going to go over the infantile again because we don't really do a lot of bracing in that population. But for our juveniles, again, smaller curves, I would highly consider you to consider part-time bracing, especially with documented progression. If you have a kid that came in with a 12-degree curve and 6 or 12 months later, they now have a 17-degree curve. Even though the curve's not huge, again, it's already gotten worse. Putting them in a part-time brace is generally well tolerated, especially when you tell them it will help avoid a full-time brace, and maybe these curves get better. And we see that, again, as I said, 70% of the time. Now, for the bigger curves, 25 or 30 degrees on up, full-time bracing is probably going to be what you need to do. That's what's been shown to be most effective in this group. And then the kids with larger curves, 40 to 50 degree curves, I still think that there is a role for bracing in those patients, especially for the juveniles. We can see curve improvement. I think that most people that do a lot of bracing have seen kids with curves in the 40 to 50 degree range get smaller with compliant brace wear. And so I really think that that's something which we can think about. We don't need to throw a kid with a 45-degree tether who's a Sanders 3. I'm sorry, we don't need to throw a kid who's got a 45-degree curve in a tether right away. Let's try a brace and see how they do. If they can be compliant with the brace, maybe we can avoid the surgery and get curve improvement at the same time. For the adolescent age group, again, the skeletal maturity is a little more variable than the juveniles. I think that if a first-degree relative had a large curve or had surgery, of a very low threshold for starting bracing, even with very small curves. Certainly 15 to 25 degree is very reasonable in this time frame. I'll also do part-time curves with the older kids. Again, if you have a kid with Sanders 7 or 8, you don't really, no matter how big the curve is, you don't need to treat them. We're just going to observe them. But smaller curves in kids past their most rapid age, past their most rapid growth, you may not need to brace them. But if you do, part-time bracing is a good option for them. For the larger curves, again, 25 to 40 degrees, literature really supports full-time bracing. Maybe there's a role for part-time with a hypercorrective brace. The literature is still out on that, but hopefully we'll have better data in a few years on that. Again, for the older kids, once they're past their most rapid growth, I think part-time bracing has a role in this population. And again, for the larger curves over 40 degrees, I still think there's a role for bracing in those with significant growth left. But remember, a kid with a 42-degree curve, they can get worse even if they're completely done growing, and we're not going to fix that with a brace. So anyway, we're just kind of going through these here. So anyway, I want to thank you guys very much for your attention. There will definitely be time for questions at the end. So thank you very much. I will stop sharing.
Thanks, Ben. And that's an amazing talk. And I love the interplay between internal and external tethering, if you will. And I think what's becoming really clear, and as a segue for John Tunney's talk, is that what's changed is that we've become so much better at our ability to correct the curve three-dimensionally in braces compared to where we were. How much of this do you think has to do with new brace types and new brace designs, Ben, versus just a better understanding of indications?
I think it's hard to tease those two things apart. I think that, none of this stuff is going to work at all without an effective brace, right? So if we don't have a brace that gives us good correction of our curve while you're in the brace, then nothing else is going to happen after that. And I do think that we have a much better understanding of how to construct a brace that gives us good three-dimensional correction of the curve. And the evidence is growing and growing that three-dimensional correction is really important in effectiveness. And the better we're able at doing that, the more effective our brace is going to be. I also think that the more correction we can get in the brace, that might, and again, don't have data on this yet, but the more correction you have in the brace, you maybe need the less time in the brace as well. So that might be a factor as well. And again, as we're developing this data, hopefully show those things.
And I want to make sure everyone understands that when Ben's speaking about correction, we're not just speaking about frontal plane correction, but we're speaking about three-dimensional correction. We actually have a couple of multi-center studies looking at the relative import of sagittal plane and axial plane correction in the brace. And John's going to speak to us a little bit more about that. Ben, from the audience, when you're talking about part-time bracing, you're talking about nighttime bracing or something different?
Right. So nighttime bracing is part of part-time bracing. I think I sort of think about it in three ways. I did have one slide on that. So full-time is really 18 hours, give or take. We talk about 16 to 18 hours. Really, there's almost no role for the 23-hour-a-day brace. Getting compliance with that is almost impossible, making it just not practical. So full-time is generally about 18. Part-time is less than that. When I talk to my patients who are, maybe of a 25-degree curve, Sanders 3, closing triradiate cartilage, like just entering their most rapid growth, I am a little bit nervous about only having them sleep in it because you don't know how much they're sleeping in it. So I will talk to the family openly about part-time, meaning 10 to 12 hours a day. So that if the kid's sleeping for 11 hours every night, that's fine. And some kids do, most kids don't. So then they need to be in it a couple hours afterwards. So nighttime only is a very specific prescription. It is also considered part-time, but it's different. And that's in the setting where you're either using one of these hypercorrective braces that you can't stand up and walk around in. So that's a nighttime brace. Or you've got an older kid, you're kind of weaning out of the brace. And so sometimes we'll just do nighttime. Or you've got a kid with a very, very small curve, 15 degrees, 16 degrees. Maybe the curve's gotten better over time and we just have them sleep in it.
And we're running out of time for this segment. There are some thoughts about whisper braces and spine core. Maybe we can revisit that in a minute. I just want to finish up with sort of voicing my agreement with you that tethering, I do think has a role, but part of the problem is that we don't understand appropriate indications. And in the early years of a lot of enthusiasm, it was used in places that it shouldn't be used. I think that many people are gravitating towards exactly what Ben's saying, which is that in the lumbar curves where you have to fuse to L4, the advantages may in fact outweigh the disadvantages. That the X-ray that Ben showed, I think, is a very successful outcome. And that's really the role for tethering in my practice. Would you sort of agree with that, Ben?
Oh, absolutely. And I meant to credit you because those were all your cases. I don't do tethering at this point, but Michael does and does a wonderful job with them and is very thoughtful about the indications for them. And as with any new technology, right, there is always some initial overuse once it gets out there because the perceived benefits are huge, which they are. But it's really, you really need to be very thoughtful about who's the best candidate for this, who's going to do best.
Yeah, and that's much the same for bracing. What I think was a resonating theme in your talk is that you can't treat everyone the same, and you really don't need to understand growth remaining, size of the curve, relative risk, and trade-offs. And with that, I think I want to thank you, Ben, and transition to John Tunney. We are so incredibly fortunate to have John Tunney as part of our group. John is, as I tell all my patients, probably the single most capable expert in the country on modern day three-dimensional braces. I tell my patients, and I think it's probably true, probably makes more of these type of braces than any other orthotist, and is also incredibly thoughtful, helping us with our research in this space. So, John, thanks very much for all you do, and I'll pass the baton to you to speak a little bit about, how to modern techniques in bracing.
All right, great. Thank you very much for the intro. Let me give you, are you able to see my screen?
Not yet.
Okay, hold on. Okay.
We could see your screen, but not the PowerPoint.
You got
okay,
it?
perfect.
All right, perfect. So I'm going to talk a little bit about bracing JIS, and Dr. Roye stole my thunder on quite a bit of topics here, so I'll focus on the things that we left out and kind of move it along a little bit. So we talked about bracing this population of kids. I've seen it described as ages 4 to 10, 3 to 9. In some ways, I feel it's almost a bit arbitrary how we're describing this juvenile case. Some kids grow up quicker and their growth patterns are different over time. Not everyone starts and ends their growth spurts at the same time. So tracking those things is actually kind of interesting. Like Dr. Roye said, juvenile curves that get worse than 30 degrees tend to worsen much more often than curves less than that. So to me, the goal really is don't let these curves get to 30 degrees. It's looking at bracing from a different perspective. It's looking at it as prevention, not a treatment. And I actually think that's like really important to what we're talking about today. So what are the options? Dr. Roye went over this quite a bit. We have observation. Observation is great if the patient doesn't want to start treatment. Observation is great if it's a first visit and the curve is rather small. But I think as Dr. Roye illustrated along the way, as these curves are getting bigger, it almost doesn't matter what the actual curve number is. If you have 2 visits in a row and the curve's 5 degrees worse every single time, I don't really care if it's 30 degrees. I think it's like more important to start treating them. A very long time ago, while I was in school, we weren't actually taught to start bracing at a certain degree. We were taught to start bracing at 5 degrees of progression. That was documented. The one thing about observation, though, is like likely if we treat every single patient that walks in the door with a 15-degree curve, we are probably over-treating some patients. So we need to take a little bit of care with like bracing everybody that walks in the door with part-time bracing. We have physical therapy as an option for these kids. One of the big barriers to physical therapy for these kids is, are they capable of doing the exercises needed to have the physical therapy work? So picturing a 4-year-old trying to do a 45-minute session of Schroth physical therapy seems a bit difficult to me. And a lot of times they have to modify the sessions for these kids. Then we need to think about, is there an advantage to actually starting the therapy early, even if it's not the true full-blown Schroth as we see it in somebody that's 15 years old? And then we need to look at, is there a downside to doing physical therapy for these kids? Are we going to burn them out too early? Are they starting too early and then they think they won't be able to do it for this long period of time and they kind of give up? It's also one of the problems with bracing as well. We need to kind of keep in the back of our minds. We have the casting options, and I don't see us casting a whole lot of 9-year-old kids. Sometimes 3- and 4-year-olds are kind of aging out of the ability to do that. It is a cast, essentially is a brace that they can never take off. So when we talk about 23-hour-a-day bracing, this is kind of the ultimate. And we've kind of shown that if you can actually wear a brace or a cast for 23 hours a day, it can be very effective. There's risk for general anesthesia, which is not something we want to be doing all the time because the cast needs to be changed quite a bit. So usually in this age group, we're switching over to bracing as opposed to casting. Then talking about bracing is truly interesting in the first place because, what is a brace? What type of brace are you using? Not all TLSOs are equal. This is one of my favorite pictures of all time. The picture on the left is a Cheneau type brace. The picture on the right is something I used to give people who had car accidents and fractures who are, 40 years old. It really has no place in scoliosis bracing. I really don't know what that is. So describing the brace is actually becoming more important, and actually SoSword's doing quite a bit of work on like the actual descriptions for braces and how they work. And I think that's really important too. As Dr. Roye spoke about brace prescription times, I kind of call it full-time, part-time, and bedtime. Often the patient walks in and they say, oh, Dr. Roye said I can wear the brace at nighttime. Well, there's kind of like nothing magical about darkness. Really what we're looking at is we want to get a certain amount of hours in the brace. When they wear it, I'm not sure matters as much as getting the actual times that they're in the brace. And then the factors in decision-making as far as the brace goes, Dr. Roye did quite a bit of work on this, but the Cobb angle, documented progression, patient and parent preference. You have some kids that are like very much into wearing the brace, and you will have some kids that will look you dead in the eye the first day and tell you they will never put a brace on. So taking that into account is actually really important. Family history, as we spoke about, scoliometer measurements is something too. If you have a kid who has a reasonably small Cobb angle, but has quite a bit of rotation on their clinical exam, that might be a reason that you're looking to brace them as well. And then the standard maturity stage also. So looking at like emotional distress and the psychological piece of this is actually really important. So about 32% of patients scored as clinically significant emotional distress. Anxiety was the most common issue with these kids. And the really interesting part of the study to me was the treatment type didn't matter, whether we were doing surgery, bracing, or observation. And that would have not been intuitive to me, as most patients come in and they say surgery is like the one thing they're really worried about. It really didn't show any difference. Like treatment in general caused anxiety for kids. Age didn't matter, and also Cobb angle didn't matter. And I found all of that like rather interesting. So speaking about like the psychosocial aspect of this, in the last couple of years, there's been way more impact from groups like Curvy Girls and Higgy Bears, looking at how do we get these patients to wear the brace because we know it works, and how can we help them and support them throughout this process. And I think it's like really important. I am definitely not a trained psychologist, and I'm definitely not a 9-year-old girl. But I'm kind of been tasked over the last 15 years as being the person that talks to them about this. And arguably, I am not great at it. So having other kids who support them is really, really helpful in getting the outcomes that we need for these patients. We try to make it as fun as we possibly can. We make colors, American flags. things that look like tattoos. And for the patients who are really worried about it, sometimes you're even trying to match skin tone so it doesn't stick out at all, to kind of ease the anxiety portion that we spoke about. Anything that we can do to make it easier is what we try to do. As far as like historically looking at case studies of treating kids with scoliosis in the juvenile range, an interesting part about this study was early on, it seemed like they treated kids with smaller curves than we do today. And some of this actually may be an impact from the insurance company setting limits to who we can treat. So in this study, they treated kids with 20-degree curves. And a lot today, sometimes some of the insurance companies won't let us treat them until it hits 25. So that's an interesting piece to kind of look at historically. This is my favorite study ever. To me, this kind of like started my interest in this nighttime part-time bracing. And I think this was done with the overcorrecting braces at nighttime. And the interesting part about it was you had these kids with 15 to 25-degree curves, and we were basically telling them if you wore the brace only at nighttime, you had a 30% chance not to progress to full-time bracing. And almost every parent I've ever said that to was super excited about the fact of not progressing to full-time bracing. And I think the kids agree with that too. When I'm done bracing, I ask all of the kids, would you have rather worn the brace full-time for a shorter amount of time or part-time for a longer amount of time? And every single one of them answers part-time. So it's really interesting the impact of their day on bracing. Right now, like you said, we're getting a whole lot better with bracing, and we're getting a whole lot better with tracking the data. So now we're able to see how much kids are wearing the brace. Historically, we didn't really have these numbers. We'd ask the kids, how much are you wearing it? And every single kid would tell you the answer you wanted to hear, whether or not the straps were perfectly white or not. So we're able to kind of track the amount of brace wear with the correction that's happening, and it's making the data a little bit more real. As I look at this page that was sent to us by our research staff recently, and we're looking at all the components that we're tracking these days, it is way more than we were doing 15 years ago, and it was basically the Cobb angle. So like getting more data and teasing it out, and we'll probably learn more new things about who to treat, when to treat them, and what we should do. So now we're able to visualize over the course of treatment how they're wearing the brace. We're actually able to see, like, are they consistent? Is there a huge variance in when they wear the brace? Do they take a week off and then put it back on? And there's some new research we're doing to see if that has any impact on brace wear at all. Intuitively, Dr. Roye and I comment on this all the time, seeing a kid who has a chart that's like completely straight and similar every single day, like seems to be a marker for success, even more than the total average hours. So I think that's something to kind of look at over time. So now we have the ability to see patterns and changes as we change brace treatment. As we transition from full-time bracing to part-time bracing, we can actually track the curves and see, like, visually, this is really appealing to be able to see. If we look at this green line on the top curve thoracic curve, initially when we transitioned from full-time bracing to part-time bracing, the curve actually went back up a little bit. And that's a little bit intuitive too. So figuring out the timing of that, I think, is really important. But if we look at the big picture, both of these patients' curves decreased over time, even though we decreased the amount of brace wear as the treatment went on. We're able to look at how often patients wear the brace, a set amount of hours per day. So on the left, we have this patient where 99% of the time they wore it 4 hours a day, 83% of the time they wore it 12 hours a day, but only 35% of the time they wore it 16 hours a day. And we're kind of wondering, the consistency measure, again, is that more important than the total hours? I'm not so sure, but we're going to find out. And then to steal Dr. Roye's last slide, because I think it's important, just looking at a patient who is 3.5 times more likely to receive a bracing prescription that's full-time as the curve gets worse, that's what everyone complains about. Every single person walks in my office and complains about wearing the brace to school almost 100% of the time. So if we can avoid that from happening and figure out how to do that and be as successful, if not more, I think that's actually a really big piece to this. So to me, the purpose of treatment is to give the patient what they need while minimizing the impact on their daily life, because this seems to be what families really want. Thank you very much.
Thanks, Sean. That was a tremendous talk, and I hope that everyone in the audience appreciates how much is happening and how much opportunity there is to improve outcomes for these kids by understanding things like, for example, the importance of consistency of bracing versus hours of bracing, or for example, the importance of sagittal plane correction, which has really been not appropriately stressed over time. John, I have a bunch of questions coming in about the sort of non-traditional braces, like the whisper brace or the spine cord brace, or some of the braces that are made by chiropractic groups. Any thoughts about any of these?
Yeah, I mean, the spine cord brace has been around for a very long time now. I was trained on it way back in school, 17, 18 years ago. We've never really found it to work well, and I think there is some data on soft bracing, and I don't really see a role for it. I was never able to get the patients even to put the brace on properly. I would say is actually one of the biggest problems. It was really hard. And then just by nature, if you make a brace out of elastic stretches out over time, and the brace actually literally got worse as you used it, and you'd have to re-up it all the time. So I wasn't thrilled with it. It was a promise of comfort, and most patients actually weren't even that comfortable with it. So I would avoid that, quite honestly. The whisper brace, I just started doing them. I saw a couple patients with them so far, with mixed reviews. Some of the patients absolutely love it. Some of the patients didn't find it more comfortable, but I find it like appealing, the ability to be able to fine tune the treatment along the way a little bit better than you can with a piece of plastic, being able to change pressures over time. I think it's interesting, but a lot more work needs to be done as far as that goes. And then as far as the chiropractic braces go, seemingly they are just not that much different. They're a little bit of copies of what's been going on before, taking pieces of other brace types. I don't think there's much new there.
We've spoken a lot about bracing part-time, including bracing at night. Can you speak a little bit about the differences between nighttime bracing and the differences between, as traditionally defined, and the differences between using a three-dimensional brace at night?
Yeah, so I think historically, if we're only using, the standard like Boston style TLSO, those weren't like hyper-correcting braces at all, essentially. So I didn't think there was a really big role for them at nighttime, to the point that we've actually done studies on adding a second nighttime brace to a full-time brace over the years to be able to get more bend out of patients. To me, that just doesn't make a whole lot of sense. So since, about 10 years ago, when we started doing the Cheneau type braces, that kind of is a combination of all things where you're getting 3D control. You can sometimes even get, correction like a patient is lying down. But I think the myth of nighttime only bracing is problematic because all of the x-rays are taken while you're lying down. So anytime I've ever made a nighttime only brace and took one of those x-rays, I was the greatest orthotist in history for sure.
You're still the greatest orthotist, even though you don't use a nighttime brace. What about the role of various questionnaires, like the brace beliefs questionnaire, to better understand issues around compliance, tolerability, or perhaps even direct the question of dose in the brace?
Yeah, I am really bad at using questionnaires, quite honestly, in my day-to-day, and it's something that I'm lacking in for sure. And that's why I love relying on you guys and handing them out to patients and having a full-time research staff to help me with these things. I think it's kind of like an untapped thing, talking to patients. We love talking about x-rays and metrics. And I think we need to talk to the patients more about what they actually need and want, because I think it can really guide our treatment when it comes to this.
Yeah, I mean, I'm sorry, go ahead.
Oh, so Dr. Vitale, I just wanted to jump in real quick and just mention a few things. I'm Prachi Bakrani. I'm one of the scoliosis PTs here. And I've been using the brace belief questionnaire, especially in kids who aren't doing well in the brace. And it's one, you have to make sure that they actually fill it out. And if they can't read, you ask the questions in front of them. It gives you a lot of insight into what's going on internally. And then I found it successful, maybe just to even increase the hours if you can really find, is it a different reason that they're not wearing the brace. So I've been using, and then right away I can tell John, Hey, John, is there a way that we can maybe change the color? Is there a way we can change, except whatever the issue was?
No, I think that's great. I think that, we all need to understand the relative risks and trade-offs of any type of treatment. For some of our patients, the brace is really easy and they're going to be high compliance kids that are not affected by it. And for other kids, they may have more of a problem. I think all we can do as practitioners is lay out what our current understanding of the relative risk benefits trade-offs are of these various treatments. John, what's your sense of brace compliance in patients who are currently undergoing or not undergoing scoliosis-specific physical therapy?
Oh, I think the compliance is much higher in the kids who are doing physical therapy as well. I honestly don't think it's one reason only. I think it's multifactorial. I think it's in part one more person to talk to. It's another touch from the system, someone like kind of supporting them along the way. And then just as far as like the physical component goes, I think braces are more comfortable to wear when you're doing physical therapy, because if you can teach your own body to be in the position that I'm trying to put you in, it just intuitively is like less struggle and not such a brute force activity. I think I almost don't want to like treat patients who are not doing physical therapy anymore.
It's nice to hear you say that, John. And of course, I kind of see the same thing, but I can tell you that across the country, that is 100% not the belief. I'm on this email chain talking about SRS's role in bracing and conservative care, and there's some very overt emails talking about how useless basically scoliosis specific exercise therapy is in changing natural history, and it's like it's mind-boggling to me because of all the not just hard data behind it, certainly as well. I mean, it's mostly European literature, but it does not invalidate it. But just all of our own experiences with using this for the past, 10, 15 years.
Yeah, I couldn't agree more. I think that's absolutely right. It sounds like Prachi could be a good topic for a future lunch and learn, modern day update on evidence of PSSE.
Yep, great idea.
Well, we are at the end of our hour together. I want to thank Prachi and Amber for the vision behind this program and the organization behind the program. I want to thank Ben and John for two amazing talks. I hope everyone in the more than 100 participants in this webinar understands how, cutting edge some of these concepts are. And you may be just hearing a little bit about them now, but some of these things I predict are really going to change the standard of care and the way that we think about best practices for treating kids with scoliosis. So obviously, I'm incredibly grateful and proud to have this amazing team to work with. Again, thank you all for joining us on a Monday afternoon during your lunchtime, and look forward to hopefully seeing you again March 4th at our next one, and then live in person on September 26th at our annual non-op CME event. Thanks, everybody.
Great. Thanks, everyone.
Bye.
Bye.